it's all possible. Now, before we get started, we do need to take care of a few operational details for this program. If you are having technical trouble, please call us at 1-800-721-4185. And for questions about today's broadcast, you can email us at info@cdlhn.com. Continuing education credits are available for this program from the CDC ATSDR online system based on 1.5 hours of instruction. If you wish to receive continuing education credits, you must register and complete a course evaluation. In order to access the evaluation and to receive credit, you must have a verification code specific to this broadcast. The verification code will be announced during the course of the program, and more details will be provided before our break. Our goal today is to give you information to help you prepare your specific region for mass vaccination clinics as an exercise and in preparation for an actual event. We will also try to bring you a broad range of information, beginning with a national and state perspective of the topic and examples of what healthcare professionals here in San Diego, San Francisco, and Sacramento have done recently to prepare themselves. Our program comes to you today really in two parts. As a convenience to our panel of national and regional experts, we have pre-recorded a series of topic-specific segments. Then at the end of this broadcast, we will be live in studio for about 15 minutes to answer your questions. You can get in touch with us at any time during the broadcast by phone or fax, and we'll include your questions in our live segment. The telephone number is 1-800-721-4185, and the fax number is 800-432-5727. All right, let's get going. And to start, let's take a brief look at the evolution of vaccination and vaccination clinics. In many ways, the history of infectious disease parallels the advancement of human civilization. As cities grew and travel and trade increased, the intermingling of populations contributed to the spread of communicable diseases and epidemics. Epidemics like the plague and smallpox devastated communities and led to the demand for prevention. In the late 1700s and 1800s, great advancements were made in basic virology and rudimentary vaccines. Success arrives in 1796 when Edward Jenner inoculates James Phipps with cowpox and has positive results. Research continues, and almost 100 years later, Louis Pasteur develops the cholera vaccine and then the rabies vaccine. During World War II, we witnessed the first mass vaccination clinics as soldiers lined up for tetanus shots. In the 1950s, under the threat of polio, entire families lined up for shots. Throughout the 20th century, vaccinations to protect against diseases such as measles, rubella, and influenza became routine and commonplace, as well as mass vaccination clinics. Mass vaccination clinics are, for many, a nostalgic memory. As a result of recent world events and preparedness needs, however, mass vaccination clinics are just as critical now as they were then. Most adults have memories of standing in line for shots at school clinics or polio Sundays. It's widely known that public health has a distinguished history of offering vaccination clinics. And now that we are planning for potential bioterrorism events in a much larger scope, public health professionals will continue to be the force behind mass vaccination and mass prophylaxis services. In this segment, panelists will discuss planning from a national and state perspective. Joining me now are Dr. Pascal Wertley and Dr. Howard Backer. Dr. Pascal Wertley is with the Health Services Research and Evaluation Branch at CDC. And Dr. Howard Backer is the acting chief of the California Department of Health Services Immunization Branch. He is also the state lead for smallpox planning in California. Dr. Backer and Dr. Wertley, thank you so much for joining us. Let's go ahead and jump right into the issue. Talk to us about what is mass vaccination and what is the urgency for public health professionals to be discussing this topic.
Yeah, so Leanne, what we're talking about in this segment is large-scale vaccination or distribution of biologicals such as antibiotics in a very short time frame to control an outbreak of infectious disease. The vaccination is not a new role for public health, but the twin threats of bioterrorism and emerging infectious diseases have lent a new urgency to our planning and our need for response capacity. Planning for major communicable disease outbreaks goes beyond intentional events like smallpox or a release of anthrax. There are numerous recent examples of naturally occurring emerging infectious diseases that require the same kind of response capacity.
Clarify for us the roles and responsibilities between the local health departments, the state health departments, and say the CDC.
Okay, well, I'll start at the national level. CDC and other agencies at the federal level will be responsible for setting policy, for making recommendations, for putting out guidelines, and for distributing vaccine to states. Now at the state level, there will be many similar activities. The states will be setting policy within their own states. States will be coordinating and integrating activities across the state, providing education, technical assistance, monitoring vaccine adverse events, distributing vaccine. But in terms of planning the nuts and bolts of these clinics that we're talking about here today, that needs to happen at the local level, because it's really the local planners that are in the very best position to be able to do this. They're the ones who know their community, they know the layout of the community, they know who the leaders are and who can get things moving, they know how to make the relationships happen that must happen in order to be able to pull something like this off. So really, you know, the important thing is in terms of getting these clinics going, the rubber meets the road at the local level.
And that's where Dr. Backer comes in.
Right, but it's also important to emphasize the concept of mutual aid, which occurs at each level in government. So as soon as the local jurisdiction runs out of resources, they go to in California at least, they go to the regional level, then they go to the state level, and then we go to the federal level. So we will all be assisting each other actually in the nuts and bolts of vaccination, setting up clinics and making the decisions. But it's true that in terms of the planning, it has to happen at the local level.
And Dr. Wortley, there is this national urgency to discuss this topic because of a federal mandate through Homeland Security, correct?
There is, and states have been receiving funding for bioterrorism planning for several years now. And as far as mass vaccination and distribution of antibiotics or whatever prophylaxis goes, it's important to keep in mind that as although states have been focusing on smallpox planning for the last year and a half or so, the same types of approaches will be used in any type of mass vaccination. And the main challenges will be the same, although there are specific differences. But in general, whether public health is mounting a response to a man-made threat or naturally occurring threat, the success of that endeavor rests upon the ability to have a good infrastructure or building blocks. And there are three main building blocks, and they have to do with having a competent and trained workforce, having data and information systems, and having organizational and systems capacity. And the latter means having strong leadership, having policy, plans and protocols in place, and very importantly, having partnerships with all of the outside partners outside of public health with whom collaboration is critical in order to successfully undertake such large endeavors.
And now that we understand the need for talking about mass vaccinations, can you tell us how is planning for these large-scale vaccination clinics any different than what we're doing right now?
Well, as you know, in general, vaccination occurs through the private sector for the most part. But when we start talking about large-scale vaccination, we're not talking about business as usual. We're talking about a response to a crisis situation. And that means that a large number of people need to be vaccinated in a very compressed time period. And in order to successfully accomplish that, that calls for a huge amount of coordination and control, working with external partners. It calls for clear communication with the public. And that's not the kind of thing that can be pulled off on the spur of the moment.
And Dr. Backer, from a state and local level, why can't we use the existing provider networks for these mass vaccination clinics?
In a crisis situation, there's a need for public health to control the response. And there are several barriers to allowing or to trying to ask the private providers to take on this vaccination. Some of those would be the need for security, the need to control the distribution of the vaccine, the need to train response staff, and the potential need for this to be done under a protocol of an investigational new drug. And then there's other things like timely and consistent documentation.
So then for planning purposes, how similar are large-scale vaccination interventions between, say, smallpox and pandemic influenza?
Well, I'll let Pascal start with that.
I'll start off by addressing a few of the issues that come up within the clinics themselves. In principle, we're talking about the same thing, getting a large number of people vaccinated in a short time period. But there are some important differences between smallpox vaccination and influenza vaccination. One of them is that because the smallpox vaccine carries a greater risk of adverse events, there are more important needs in terms of screening and consent that are minimized for influenza vaccine because people are familiar with it and the risk of adverse outcomes is much smaller in comparison. In addition, in a smallpox vaccination clinic, there's a need to identify those people who are contacts of cases or people who are ill potentially, so there's a triage function that wouldn't exist in an influenza clinic. There's also differences in staffing requirements because there's a greater need for physicians in a smallpox clinic, and also because of those greater administrative needs having to do with screening and consent, in general there's a need for more stations through which patients will move and more people to staff them. And then a last point, just about the logistics within clinic, is that the smallpox inoculation per se is actually easier to administer than an injection for influenza. There's no need to refill syringes, which is actually a pretty labor-intensive activity when you think about the number of people streaming through a clinic, and there's no concern about accidental needle sticks.
For staffing, I think you have to start with your public health department, but don't just limit yourself to immunization staff or even communicable disease staff. Poll the entire department and survey them and find out what their skills are so that when the time comes, you know who you can put into the various positions and what roles they can play. Because in a crisis of this nature, any available and capable staff will be redirected to this effort. So it won't be enough for them to say, that's not my job. They won't have that option. And then local health departments should all look at instituting Medical Reserve Corps and Citizens Reserve Corps teams. These are funded by federal grants and require community partnerships. But they're a unique resource and a way to involve other members of the community in your response. And there are a lot of people who do not want to sit on their couch and watch it on TV. They want to get involved.
Many health professionals have heard about this 10-day time frame, but could you talk to us about the origin of it? I believe the federal government set that time frame. And also, when does that begin? Who makes the decision of when this time frame begins?
Well, the 10-day time frame refers to smallpox vaccination. Should a smallpox case occur, the hope is that the area where it has been decided that the population should be vaccinated can be vaccinated in 10 days. Now, why was 10 days selected? There's a number of reasons. One is that we want to be able to mount a timely response, obviously, to a threat like that. The average incubation period for smallpox is 14 days, so you could say that trying to get the area vaccinated in 10 days is a conservative approach to that and a safe approach. And I think most agree it's a difficult goal. It's a high bar that's being set, and it's an important goal to strive for. So there's the epidemiologic reason. There's the fact that we need to be able to respond in a timely manner in relation to that. And you know, it's important, the more we can reassure ourselves that we can vaccinate people appropriately post-event, the less there is a need for pre-event vaccination. And really, we much prefer to vaccinate people once there is an actual threat of smallpox, because in terms of risk-benefit, it's a much more favorable situation than vaccinating people before there's any smallpox around.
Now, preparedness is the focus here in terms of mass vaccination clinics, and part of the planning of preparing for public health professionals is these exercises. Can you talk about the importance and the role of these exercises?
Yeah, exercises are critical, and we'll be hearing a lot more about these later, but I think it's important to think about a couple of direct benefits from exercises. I mean, one is on a very concrete level, is that if you conduct a clinic exercise, you get a good sense of whether things flow as you had thought they would, and you can work out kinks in the system and figure out how to use your staff optimally, et cetera. Another benefit, which is a little less concrete, but is that ideally an exercise would be developed in collaboration with those partners that will need to be involved in the real thing. and those include partners in the healthcare system, police for security issues, for example. And those may be partnerships that don't exist already, and by developing the exercise, it really helps promote this collaboration that needs to occur. Just important to keep in the back of your mind that a planned exercise doesn't fully simulate a real situation. And specifically, as I was talking about security needs before, an exercise can't necessarily tell you how much security you might need. That's just something to keep in mind.
Okay. And Dr. Becker, did you have anything to add?
Practice makes perfect, and until you practice, it's almost impossible to be able to conceive of all the partnerships, personnel, logistics that you'll need. And so an exercise is a way to practice this, even if it can't possibly be a realistic scenario.
Okay. Some very good information that you shared with us. Thank you so much for your expertise. Dr. Pascal Wertley from the CDC and Dr. Howard Backer from the California Department of Health. Thank you so much for joining us today.
Thank you, Leanne.
And we'll be right back. As you know, there are many, many details to think about when you plan a clinic. In this segment, experts from San Diego County will walk us through their recent exercise and share their experiences and lessons learned. Joining me now are Miss Sandy Ross and Mr. Steve Wood. Miss Sandy Ross has more than 30 years of experience working at the County of San Diego Health and Human Services Agency. Currently, she is the immunization coordinator for the county immunization program, and in the past has conducted school-based immunization clinics and swine flu mass vaccination clinics. Mr. Steve Wood is the chief of the Emergency Preparedness Division of the County of San Diego Health and Human Services Agency. He is the CDC Bioterrorism and HRSA coordinator, as well as the MMRS director for the County of San Diego. Steve and Sandy, thank you so much for joining us and sharing your expertise.
Thank you.
Steve, you helped plan the operating side of this mass clinic, and then you were the clinical director of this exercise. Talk to us about why San Diego held this drill, and what are some of the practicalities of holding exercises like this?
San Diego has been preparing for events like bioterrorism, chemical terrorism, et cetera, for several years. And our public health leadership team, led by our public health officer here in San Diego, decided it was time to test our ability to do mass vaccination in an emergency situation. We decided to do an exercise involving a scenario that would allow us to test that. We used a large SARS-like outbreak where it became prudent to provide a vaccine to the general public, again as a scenario base. We decided to use flu vaccine and open a flu clinic as an incentive to bring the general public into the clinic to help us bring the numbers up so that we could actually test the situation. It is important to understand, and what San Diego did, we did not provide a flu clinic. We did an exercise and all the components associated with it. As a component of that, there was a ability for us to provide flu vaccine to the general public.
And actually that flu vaccine was an incentive to draw people into this exercise, correct?
Absolutely, absolutely.
Let's talk about the training and the recruiting of staff. How did you facilitate this particular mass vaccination clinic, and how did you recruit some of these people?
Well, as Steve said, our main goal was to make sure that we got our staff trained. I mean, this was an exercise so that we could make sure that staff that we would be calling on had an opportunity to experience the clinic. And we were very fortunate in San Diego. We have a staff called our BT nurses. And our BT nurses are stationed one in each of our public health centers, and they were key to the training and recruitment. The BT nurses helped to modify the protocols that we pulled out of our mass vaccination plan and make those job descriptions relevant to the clinic that we were holding. And then they were also involved in recruiting. They helped us to recruit. We ended up having 81 Health and Human Service Agency staff at the clinic. Now, they weren't all nursing staff. We did have like about 60 of those were nurses. We had physician, pharmacists, but we also had about 30 folks who did not have any clinical expertise. And they also participated and got to experience doing the clinic. The training then involved using those job descriptions that were modified. We had the BT nurses actually explain to the staff as we broke up the staff into different sections in the clinic, explaining to them their roles. The BT nurses were each leads for their section, and in terms of recruitment, of course, we've got this nice mix of folks, and we want to use the people who have the best clinical expertise to do the clinical jobs. So the role was to start off saying who is comfortable giving immunizations, because just because you're a nurse doesn't mean you're comfortable giving shots, and those people who were most comfortable giving shots were identified first. So we filled that station first. Then people who were comfortable doing the counseling, because that's the other clinical area of expertise.
A lot of people involved in that. And Steve, I know you were part of the staff orientation that day. What did that involve?
A key component of this is, other than your core command staff inside it, you've got to be able to train people the day of an event.
Right.
And so that was a key objective. And so we brought the folks in a couple hours early. We set the clinic up, and then we actually trained them on how to operate this clinic, sent them back out to each one of their stations, and let them orient a little bit more with the BT nurses who were station leads, so that we could truly test the ability to train staff on the day of, whether they're community volunteer staff or whether they're our own staff. Because 2 years from now, of the 81 people from HHSA, who knows, we could have less than half of them actually trained beforehand. So that was a key component.
And in a real situation, you would literally have overnight to set something like this up.
In a real situation, we would have literally overnight to set up several of these. We would not be running this as only one clinic. Most likely there would be, you know, several of these clinics. So having this workforce trained and understanding the concepts allows us the flexibility of the intensity of the training during an actual event when you've got multiple open sites is reduced somewhat.
And this particular drill, the first one in San Diego County involving mass vaccination clinics, testing, emergency response, and preparedness, you had 3 months to prepare, and you said that, you know, that was really challenging, and that was 90 days.
Correct.
So what are, that was one challenge. What are some of the other challenges that you had?
One of the our biggest challenge was the fact that we wanted to provide the flu vaccine during the flu vaccine season, obviously, and the perception is that we wanted to do it early in the flu vaccine, so we needed to get it in that November time frame.
Do you think that the incentive of the flu shot actually brought more people than would have originally shown up?
Oh, absolutely.
And Sandy, who paid for all the flu vaccines that you used in this exercise?
Well, most of it came out of Steve's budget. Thank goodness.
And that's exactly, again, that's why we said the incentive of you know, we understand that you've got to have an ability to do this, so we figure out ways to do it through our existing funding sources and internal funding.
Did a lot of your emergency planning for other clinics and other situations, did it cross over, and did it help in the end with this particular situation?
The lessons learned from this work in an all hazards approach, almost all of our planning isn't specific to one pathogen or one chemical. We look at it from a, if it works for this, it should work for that. So much more of a global perspective.
What are some of the lessons that we learned from this exercise, and was there anything that surprised you in particular?
We learned that our staff was awesome. They are skilled, they were flexible, they were enthusiastic, and should we have an outbreak of something, we've got an awesome staff who can do a great job. But we also learned that whatever we thought we had snookered wasn't. We could improve just about everything that we did. We thought we had all of the sort of paperwork issues handled very well, and figured out that we could have done a lot of those better. We had bottlenecks at the entry where we were doing our triage, our greet and triage area. That staff felt they needed something to do, and they wanted to hand out paperwork, and that slowed them down, and that should have been in the next station. So we'll move that to the briefing station for our next exercise. We found that the people who were in the briefing area lost their voice. I mean, they are talking so much to move people through that they were losing their voice. We needed to have either something recorded, better signs to do instructions, better directional signals, or rotate the staff so that they didn't get stressed out losing their voice. In the area where we were doing our counseling, we were way too close together. We had either had too many people doing that counseling because there was never a bottleneck at that station, so maybe we could have done it with fewer people. But in any event, we didn't have the kind of confidentiality that we needed. Too many people too close together. When they left that section and went over to get their immunization, we had a huge bottleneck because they went through that station so quickly that they were bottlenecked before they could be routed to somebody giving a shot. And giving a shot didn't take very long, but so many people coming through bottlenecked, and we didn't have enough room. We didn't have tape or some way to separate people or make for lines so that people didn't get just jammed in there.
The biggest lesson learned is the fact that our staff now understands the flexibility component. The loopholes we threw in, they were able to adapt and overcome them. Our next step is to actually do another mass vaccination clinic, only we're going to open more than 1 or 2 or 3. We're going to open several in the community so we can more stress the command and control and the coordination between these 2 or 3. And we'll do some that are mass vaccination and some that are actual medications that you can take orally.
So much to consider. Sandy Ross, Steve Wood, thank you so much for joining us and sharing your expertise.
Thank you very much.
Thank you. Dr. John Brown, the medical director of San Francisco's Department of Public Health, says, in a disaster, you don't rise to the situation, you sink to the level of your training. Last summer, San Francisco's Department of Public Health facilitated a smallpox vaccination exercise. Let's all learn from their ambitious project. Here now is Miss Amy Pine. She is the Immunization Program Coordinator for the City and County of San Francisco. She served in the Peace Corps from 1990 to 1992 in Mali, West Africa. Amy, thank you so much for joining us.
Thank you.
Now, this large-scale smallpox drill last year in June. Can you talk to us a little bit about what happened and why you held that exercise?
Well, it was basically to test our assumptions about what we thought was necessary in terms of clinic flow, staffing, supplies, to move a lot of people through a clinic quickly, which is part of our overall plan in San Francisco.
And you said a lot of people. In this case, in your exercise, how many people did you have involved?
Well, our goal was to move at least 312 people through an hour. We needed about 200 staff people to make this happen, and the drill wouldn't have been worth much if we couldn't have gotten at least 700 volunteers to come to the exercise. We were lucky, and then we got 1,350 people to come.
Wow, almost double the number that you had wanted. How in the world did you get 200 staff members together and fully trained for this exercise, and then deal with these 1,300 volunteers?
We marketed the event in advance, far in advance, to our Department of Public Health employees. Everyone that worked at the drill was employed by the Department of Public Health in San Francisco. And it was put out in voicemails throughout the health department, in emails, in managerial meetings, that this event is going on. Please dedicate your day to working at this event. To get the volunteer patients, that was even more of a challenge because we had to put it out into the community. We developed flyers that were in English, Spanish, Russian, Chinese. On all of our marketing materials, we said that we wanted the people coming to the drill to be representative of the diverse population in San Francisco, so we welcomed families, the elderly, children, people with disabilities, people who do not speak English as their first language or at all. And we did a lot of community canvassing. We attended community meetings. We put ads in non-English papers. We put PSAs on the radio stations, and we sent out just about every communication that we could think of to get people to come to our drill.
In terms of the exercise itself, based on what had happened, do you think that you had enough time to fully plan it? Were you actually prepared for it, and what were some of the lessons that you learned?
We actually had 61 working days to plan the whole thing.
Wow.
But in retrospect, I think it's probably good that our timeline was so short, because in a real emergency, A, you'd have less time than that, and B, it didn't really allow us any time to dilly-dally at the health department. We knew that we had this drill coming out. We knew that it was going to happen on June 17th. Made it a reality. We did learn a lot about training. The training that took place for the drill, the exercise was divided into 17 different areas.
Wow.
And each area had a leader assigned to that area. We knew in advance who the leaders would be, so we invited them to a 2-hour training the day before the event to just give them an overview of everything that would be taking place in the drill overall, as well as in their area, and told them that they would be responsible for training everyone who would be working in their area the next day. The next day, the day of the drill, the area leaders basically had 45 minutes to train everyone who would be working. Now, in retrospect, that wasn't enough time. It was, I mean, we pulled it off. It was enough time for the drill, but in a real emergency, it wouldn't have been enough time. And so that was one lesson that we learned. Another lesson was that we needed more security. We had recruited close to 200 staff people to work at the event that day, but we didn't have any people tasked specifically with just being security guards. We learned a lot of lessons in terms of the signage that needs to be used in an area like that. You need some creative things that are tall, because we couldn't hang anything from the ceiling, so some people suggested balloons or large poles, but I think the best suggestion was to have color tape on the floor and just say to people, follow this color tape.
Some very practical lessons.
Yeah. For the staff, we asked in advance if people spoke another language, because we had to make sure that all of our materials were produced in English, Spanish, and Chinese. Those 3 languages we knew we would be handling at the drill. And we needed at least one Chinese and Spanish speaker in each area of the drill. So we would ask the staff in advance, do you speak any other languages?
And you guys already have plans in place because you administer immunization clinics throughout the city and the county. How did those plans cross over into the planning process of this particular smallpox clinic? Or can it? Is it apples and oranges? Because you're dealing with sometimes fear and hysteria with smallpox and spending more time with the patients.
Yeah, well, the mass clinic experiences that we were used to were more for flu vaccine, and we've been doing those for so long that I think people pretty much have a handle on at least the elements involved. For smallpox, we had never done anything like this, and it's a very complicated vaccine, so the planning process was a little bit different. The fact that it was just all one day, you know, you come in, you learn this, you open your doors to the public, and then you close the doors, have a debriefing session, and go home. It was not something we had ever tried before.
The mentality behind a mock exercise, everyone knows it's pretend, but in preparation and administering what happens during this drill, how real is it? Is there a difference between what the volunteers do during this drill as opposed to what would really happen in real life?
We tried to make it as real as possible. That was one of the tenets of the steering committee. We said, okay, every time we are approached with a decision as to should we take an easy route and control it, or should we make it harder and just make it real, we chose to make it harder and try to make it real. Now, we didn't actually have any smallpox vaccine on site or any needles or sharps on site. We just didn't want to deal with that potential liability. So what we did was we used plastic stirring straws, thinking that they were small, and we dipped them in vials of sterile water, and then the nurses had followed the same immunization protocols.
And so the lessons that you learn from this, you think it sets the stage for a very good plan for future mass vaccination clinic exercises?
Definitely. It makes such a difference to see it all in person, experience it. It was really wonderful to have all of these different people from the health department coming together that normally worked in all different jobs in the health department, but working in this drill, and you got to meet a lot of people, and you got to experience firsthand what it was like to deal with the public all day long and experience the level of exhaustion that you might feel in a real emergency. And it really helped us realize what would be necessary in a real event.
So you suggest this for all other public health professionals?
Done the right way, it can be very beneficial.
Amy Pine, thank you so much for sharing your fascinating experience with the drill in San Francisco, and we thank you for being with us today. Running flu shot clinics are practically a routine part of many healthcare workers' lives. In this next segment, we'll take a look at a unique alternative to traditional clinics. Joining me now is Miss Sally Shaw. Sally Shaw has been a registered nurse for 24 years and has worked in the field of public health for 22 years with Sacramento County. She has held the position of immunization coordinator for 10 years. Ms. Shaw, thank you so much for joining us.
Thank you.
Your immunization program has been offering these drive-through clinics long before you even came on board.
Yes.
Tell us why they offer these drive-through clinics and what are some of the pros and cons?
Sure. Well, many years ago, we found that it might be convenient. That was sort of a guess at that point in time for a lot of our seniors to come to drive-through clinics. And over the years, we found that our thought was really supported. Many seniors are on oxygen, don't walk well. It's difficult to get into large buildings for flu shots. And so over the years, we've offered more and more of them and have found them to be quite effective. The pros are definitely for the seniors. They can come in, they're not having to get out of the car. Multiple people can come in one vehicle, which is sometimes an issue. We also help board and care homes or assisted living facilities that don't have nurses that work there. They bring them in vans too, so it's very, very convenient for them. I'd say some of the cons to that is it does require some extra planning. You do have some issues with weather from time to time, so it's really, you have to take the whole process where you don't necessarily worry about all the vehicle things in an indoor clinic. You definitely have to worry about that with a drive-through.
What about for people who happen to walk by, don't have a car, they're at the bus stop or are riding their bicycle and they see this clinic? What happens to them if they want to be vaccinated?
If you start letting people walk through, you've just defeated your whole purpose of having a drive-through. So if we have people show up, what we try to do is to educate them that this is a drive-through. So next year, bring your car. But then we try to accommodate by putting them in another car, and these seniors are so helpful to one another. If that's not working, then we get in one of our cars and drive them through, but we're really reinforcing to that individual that when we say drive-through, that's what we mean.
You touched upon the issue of liability, and liability also lies in the hands of the many volunteers that you have. Talk to us about how important it is to recruit good volunteers, and how do you train all of them?
Prior to the clinic starting, usually about 1 month prior, I actually hold a training session at the Red Cross that I offer CEUs to the nurses, and I go through, this is this year's flu clinics, this is what we're using, these are any changes that we're encountering, this is what to expect. And so it kind of updates them, and it is a requirement that they attend that training at least once every 2 years. Most of them come every year.
Yeah, it sounds like you have established relationships with a lot of these volunteers, which is an important part of the program.
And we usually don't take volunteers that are nurses unless they go through the Red Cross process. And part of it is that Red Cross has so many opportunities. We want to help them recruit nurses, but that the other point, it's a point of contact, so we know that everyone is being treated and trained the same way.
Okay, so one part of running these clinics is training these volunteers. Another challenge, however, is storing the vaccine. Can you talk to us about that?
Especially when you're outdoors, and if we get lucky and run the clinics on October, it can be pretty warm. Normally if it's cold or rainy, I'm not as worried, but if it's warm, what we do is that we make sure we bring several ice chests. The vaccine that we're not using at that point is really stored in one ice chest, not opened a lot. Thermometer is in there to check it. The one that we're using, we still have a thermometer in it, but we're moving that vaccine pretty rapidly, and we can run through it pretty fast. We normally, drive-thrus can see anywhere from 700 to 1,000 people, so we can go through a lot of vaccine. But we're monitoring it carefully. We don't want a lot of it open, sitting around. Usually I have one charge nurse with the Red Cross, and she is in charge of monitoring that vaccine.
And I remember many people this past flu season running to get vaccinations because they heard that they were in low supply. And you probably faced vehicles with multi-passengers in there. How do you deal with situations like that?
Well, we have two sorts of circumstances that we deal with. Just a regular passenger car that has multiple occupants in it. What we tend to do is we have the driver drive up, put the car in park, and take their foot off the gas. And we say this routinely. It seems so basic, but that's a really important feature. And what we have done is that we will immunize the occupants other than the driver first. We always do the driver last. And the reason for that is sometimes the driver can't see what's behind them. They're a little bit nervous about them themselves getting the shot, and we wait to do them at the very end. And that way we don't have a needle kind of still in somebody's arm or not quite finished with what we're doing. Now, if we have board and care homes or assisted living facilities come, we have a special place that we park those vans. We don't bring the people off at all. The nurses work in teams where they're going on board. One nurse is giving, the other is holding the supplies in the contaminated waste container, and you're kind of working together with that. And it seems to work very well.
And that allows the cars to go through faster.
Right.
Okay.
Right.
Up until this point, we've been talking about vaccinations for influenza,
Right.
but part of the national discussion in mass vaccination clinics is also about smallpox.
Right.
Can you talk to us about the difference between running a flu clinic versus a smallpox clinic?
I think it might be very challenging to run drive-through clinics. I'm not saying that you couldn't do it, but you definitely would have to keep that in mind. You wouldn't necessarily be serving one segment of the population like we do with flu with seniors. You would be serving, you know, a wide variety of ages. People may be scrambling to get the vaccine, so I'm not sure that drive-thrus could make it. I could see there'd be portions of it that might work, but the overall operation of a smallpox clinic might be best to leave inside. And why I say that is that there is some definite history taking that you're going to need to do with that patient, much more so than with influenza, to make sure that they are well, that they are the right candidate for smallpox vaccine. That's going to take some time.
Okay, during these clinics, you have all these volunteers, and we saw them wearing the orange vests.
Right.
How do you identify staff at these clinics?
Right. If you are online, meaning if you're not in one of the RVs that we have where we fill the vaccine, you must have an orange vest on. Part of that is to identify the staff member, and part of it is for safety, so people coming can see an orange vest. They're used to seeing road workers with orange vests on, so we really, and myself included, we all have to have those vests off if we're online.
Tell us, finally, over the last 10 years that you've been serving as immunization coordinator, what are some of the valuable lessons that you have learned that you can share with everyone else?
I think one of the big things is that you have to be flexible. That was a challenge. You know, you work for months and months and months. It's almost like planning a wedding in a way, except you've got 25 or 30 of them to go through day after day. But I think the big thing that you have to know is to be flexible and have a backup plan, and to know to make sure that your message is very consistent. Stick with the same message. Don't make it too complicated for the public.
Well, Sally Shaw, you do some incredible work as the immunization coordinator of Sacramento County. Thank you so much for sharing your expertise and just joining us today.
It was a pleasure. Thank you.
All right, thank you. Now, before we go to break, we have the information you'll need to receive continuing education credits.
If you wish to receive continuing education credit or a certification of attendance, you must register and complete an evaluation through the CDC Continuing Education and Training online system. Please write down these two important numbers. The course number is SB0146. The course number for the webcast is WC0046. Another critical item is the course verification code, which is the same for both the satellite broadcast and the webcast. Write down this code, LB114F. The code must be in uppercase. Please write it down. That's LB114F. The capital letter L, the capital letter B, the number 1, the number 1, the number 4, and finally the capital letter F. You can also receive instructions for the online system through our faxback system. Call our toll-free number at 888-CDC-FAXX. When prompted for a document number, request document number 130012. That's document 130012. Then enter your fax number. The document will be faxed to you in just a few minutes. Here is the address for the CDC ATSDR Training and Continuing Education online system, www.ppO.cdc.gov/PHTNONLINE. When you get to the website, an extensive help function can also assist you in the registration process. After you are registered, it will only take a few minutes to complete the course evaluation and receive your CE certificate. In addition to the online help function, you can receive assistance by calling CDC at 800-41-TRAIN or 404-639-1292. CE unit personnel are available Monday through Friday from 8 a.m. to 4:30 p.m. Eastern Time. You can also receive assistance by email. The address is ce@cdc.gov. The continuing education staff will be happy to assist you with the log-on and registration process. The evaluation for this program will be active on the online system until April 19th, 2004.
Hello and welcome. I'm Violet Macias, Executive Director of the California Distance Learning Health Network, CDLHN, a nonprofit organization and project of the San Diego State University Graduate School of Public Health. CDLHN pursues a strong mission to produce, promote, and provide quality distance healthcare education throughout California, the nation, and the world. We work to ensure a competent and knowledgeable public and personal healthcare workforce using the most advanced communication technologies available today. It all started back in 1995, when we were founded through the collaboration of the 4 schools of public health at San Diego State University, University of California at Berkeley, University of California at Los Angeles, and Loma Linda University. In order to reach an increasingly international audience, CDLHN translates its award-winning English language materials into Spanish, including our bilingual website, cdlhn.com. When you visit our website, grab a cup of coffee, sit back, and click on our Public Health Cafe webcast to enjoy 20-minute health programs. For additional materials, our distribution department ships out hundreds of videos, such as immunization techniques, safe, effective, and caring, CD-ROMs like Spanish for the healthcare worker, and smallpox vaccination basics, and publications including our quarterly e-satellite program guide and newsletter.
CDLHN is familiar with the needs of the healthcare workforce, and we're here to serve them. In addition to producing quality distance healthcare education, we also promote and provide convenient access to continuing education opportunities on a variety of topics. We also get this information from a variety of sources, such as the Centers of Disease Control and Prevention and other federal, state, and local organizations.
In collaboration with the California Department of Health Services Immunization Branch, CDLHN launches successful media campaigns addressing health disparities. The Spanish language puppies commercial encourages immunization of Latino infants and toddlers. The Grandman campaign sends that message to the African American community, and the over 50 advertisements encourage flu immunizations. A partnership with University of California TV in a March of Dimes campaign promotes folic acid intake to prevent birth defects.
CDLHN's statewide media campaigns, in collaboration with our partners, are not flash-in-the-pan, arbitrary attempts to get on the news or get our logo in the newspaper. Our media campaigns are highly research-based, goal-oriented, strategic plans that align with public health initiatives to address health disparities throughout California. We create awareness of these health disparities, we influence health behavior, we improve the public health of Californians, and we ultimately make positive social change.
Much of this good work results from strong, solid partnerships. NetPAC and our website, Total Recall Learning and our CD-ROMs, KPBS and our video productions. We thank our sponsors like Aventis Pasteur, and the value support from the California Department of Health Services, the Centers for Disease Control and Prevention, and the Public Health Training Network. Satellite technology, public health continuing education, communication, and partnerships. The whole is even greater than the sum of its parts, and that's why CDLHN truly demonstrates learning without limits.
Before the break, we focused on several mass vaccination clinical exercises. We also talked about critical issues and lessons learned. In this segment, our panelists will discuss the importance of communications. Joining us again are Miss Amy Pine, Miss Sally Shaw, and Miss Sandy Ross. And I'd like to introduce Miss Leslie Ridgway. She has extensive media relations and communications experience here in the healthcare arena, including work during the 2003 wildfires, the 2003 flu outbreak, and the smallpox response launched by the federal government in 2002. And Leslie, you deal with the media directly.
All the time.
All the time. So talk to me about some of the challenges in communication.
Well, for this particular drill, what we had to do was try to get this done in a certain period of time, and we had some concerns too about what to do to make the story interesting, to get people to show up and volunteer to roll up their sleeves and get a shot. But what really worked was the news media showing up to the event and broadcasting live from the event. And that brought a lot of people. I actually asked the people who were checking folks in to do a little informal poll to find out how people heard about this, and most of them said the live broadcast.
In planning for communications, are there any catchphrases or words that you use and words that you try to avoid in trying to publicize your event or getting publicity?
Well, in San Francisco, we obviously were conducting a smallpox vaccination clinic, and we didn't want to instill any unnecessary fear in the community, so we didn't use the word smallpox in any of our press releases or marketing materials. In anything that was written down, we did not use the word smallpox.
One of the strategies that I think worked well in our community was to ask the community to partner with us. We were asking people to help the county to do this drill because doing this drill was going to help us learn better how to protect the community and tried to have the community be a partner in that.
And Sally, how do you get the word out to all the different communities that especially are multicultural, multilingual? How do you reach out to them and communicate with them?
We found one of the best things we could do is advertising the penny saver. I mean, I never would have thought the penny saver, but it really made a big difference. And then the neighborhood newspapers, we reached out to them. The other thing we planned is that we have clinics in those neighborhoods. So people that are familiar where that particular church is or community center, they're not driving 10 miles to an area that they don't know and never go in. It's staying right in their community. So we really not only reached out to the media in that community, but we placed the clinic in that community also.
Okay, and Amy, how did it work for you?
We said that we wanted the population who came to the drill to be representative of the population that lived in San Francisco. So we encouraged those with disabilities to attend, the elderly, children, families, monolingual, non-English speakers. It was on every single piece that was written about the drill, we said, please come.
But in an actual event, people are certainly frightened. How do you try and avoid over-frightening them too much, especially in doing these mass vaccination exercises?
Honesty is always key. You don't want to minimize something that shouldn't be minimized, and you don't want to overblow something that is not a problem. And sometimes when you're in the middle of something that's a hard call to make, you don't know which side of that line that the reality is. But you need to be as honest as you can about the situation.
Whoever the spokesperson is, I mean, and depending on what the disaster may be, to really be a calm presence, empathetic, like you mentioned, also compassionate, and not really veering from being that way.
Consistency.
Yeah, consistency.
Okay.
I think too, everyone said the right things, but I think just keeping the message simple. Sometimes we know a lot of things and we're not hiding it from the public, so knowing when to give just the simple message.
Very good advice from all of you. Sally Shaw, Amy Pine, Sandy Ross, and Leslie Ridgway, thank you so much for joining us to talk about communication.
Thank you.
Thank you. Thank you.
Now let's change our focus just a bit. Healthcare workers are used to supporting the physical health needs of the community. In this segment, however, we'll talk about supporting the psychological and mental health needs of both citizens and staff. Joining me is Ms. Diane Myers, a licensed public health nurse and psychiatric clinical nurse specialist. Diane, thank you so much for joining us.
Thank you.
Mental health is such an important component of this pre-planning for disasters and emergency situations, but it's also very overlooked. Can you talk about that?
Mental health is being included because we've realized the long-term impacts. So it's a very important aspect of disaster planning.
And in disaster planning, I think many people tend to focus on the victims.
Correct.
But there are also the hundreds of staff and volunteers who are working to service the community, who may also have an emotional toll as a result of that.
Correct.
Can you talk about that?
Yes. We know that disaster workers are just as vulnerable as citizens to emotional and psychological reactions. They see the same things. They may have the same things happening to feelings of vulnerability in terms of their own family, their family's health, so on and so forth. So what disaster responders tend to do, however, whether it's police, fire, or public health responders, is to put their own needs aside in order to fulfill their responsibilities and their roles. So it's long been a myth that public employees, disaster workers, would abandon their posts and go to take care of their own families. That doesn't happen. What tends to happen is that workers invest themselves in their jobs to the extent that they may suffer in terms of both fatigue and stress in the long run. So we want to encourage public health personnel as they're planning for bioterrorism events to be aware of the impact of these events, not only on the citizens but also on themselves as responders, so they can care for their own health as well as the community's health.
Can you offer some advice on how these agencies may plan for the needs of just the emotional impact, not only to the citizenry, but also to their own staff?
Sure. I think one thing that is really helpful is to have mental health at the planning table. In terms of mental health can provide consultation in terms of the common reactions that we'll see in citizens, so that we're planning from a public health point of view based on reality and not on some myths. There are a lot of myths about human behavior and disaster. For example, many people think that we need to plan for mass panic, when in reality, panic very rarely occurs in disaster situations. In fact, there's very good news that between 60 to 80% of people in the general citizenry in the community respond very calmly, very adaptively, reach out. Adults help children, able-bodied people help people with disabilities, that you really see a pulling together and a kind of heroic response in disaster. So mental health can be helpful by giving accurate information about human behavior in disaster. Mental health can be helpful by participating in exercises so that the scenarios are realistic in terms of human behavior. And mental health can be an important component of response to emergency situations.
Are the response workers reluctant to share their stress? And especially, I would imagine that a lot of that stress doesn't surface until long after the event.
Well, one of the things that's helpful is to, in preparing our public health departments, for example, for what might actually occur in mass vaccination clinics, to do part of their training to include disaster worker stress reactions. So they're kind of getting an emotional inoculation, if you will, ahead of time about how to recognize when they're getting fatigued, how to know when they need to take a break, how to know when they've been working too many long hours, so that you enable them ahead of time to be able to monitor themselves in terms of self-care and watching out for their coworkers, kind of buddy care. And it seems to work really well. To give them those kinds of skills ahead of time so that they can use them to take care of themselves when the event actually happens.
Is there a difference between the emotional toll of workers that work a mass vaccination clinic per se than, say, like a bombing or a larger terrorism event?
Well, I think the difference with a bioterrorism event, as opposed to the attacks of 9/11, where there was such a horrific attack and it was so visible, is that with a bioterrorism event, the agents that has been used, or the disease, the organisms, are number one, invisible. You can't see them. You can't smell them. You don't know that they're there. So that I think the major reaction that we need to plan for is anxiety and fear. And that's why risk communication and informing the public clearly about what the risks are, what the protective actions are that people can take is so important.
Specifically for people who are staffing some of these vaccination clinics, what are some of the symptoms that they might look out for?
Well, one of the things that happens is that people get fatigued and don't recognize their fatigue. So they may notice that they're starting to drink more coffee and caffeine, trying to keep their energy up. But some of the things that happen when people are tired are mental changes, cognitive changes. People begin to become forgetful, can't set priorities, can't problem solve as well. People get irritable, short with their coworkers. Over a period of many days, if the clinics are going on for a long period of time and people are getting tired, we often see an increase in staff members' allergies or their health begins to decline, not sleeping well at night. So again, coming into work fatigued and then getting fatigued over the course of the day. Other symptoms are things like headaches and stomach aches and appetite changes and so on. And I think one of the key ones that I often look for is when staff members begin to feel that they're indispensable. No, I couldn't possibly take a break now because there's so much work that needs to be done. When you're seeing that in a worker, it's really time for them to at least take a little bit of a break and kind of get their energy back.
Right, but they have to realize that, and they have to be the one to seek out the help, right? And isn't that the difficulty?
That's the difficulty, because I think that disaster workers, whether they're public health workers or police and fire personnel or mental health workers that are working in disaster, tend not to be terribly insightful about our own stress. And that's one reason that we as mental health workers suggest that any disaster response workers work in a buddy system and keep an eye out for each other. If you notice that the person you're working next to in the immunization clinic hasn't taken a break for several hours and isn't drinking any water and hasn't eaten their lunch, to make an agreement to remind each other about taking care of yourselves.
Diane Myers, thank you so much for joining us all the way from Monterey County.
Yes.
Today's show is designed to raise your awareness, open your eyes, and help you prepare. In this segment, the panelists will introduce some tools and resources. You'll hear from experts who have experience in both emergency planning and response. Joining me now are Dr. Linda Quick, Mr. Gregory Smith, Dr. Christian Sandrock, and also joining us once again is Miss Amy Pine. Dr. Linda Quick is a medical officer and epidemiologist working for the Emergency Preparedness and Response Branch of the National Immunization Program at the CDC. Mr. Gregory Smith works at the Red Cross National Headquarters, focusing on external relationships and partner management. Dr. Christian Sandrock is currently an assistant professor at the University of California Davis Medical Center and a medical director for the Hospital Bioterrorism Preparedness Program for the state of California. Okay, and let's begin right now with Amy. And Amy, as the immunization coordinator for San Francisco County, your health department planned an exercise for a very densely populated, multicultural, multilingual community. Talk to us about creating a plan that's not just a one-size-fits-all.
It is not possible really to have a one-size-fits-all plan for the community, but when you get down to the clinic itself, the components of the clinic, I think that they're pretty standard.
Okay, and there are many tools out there available to the public health personnel to develop these plans, and among them is technology. And Linda, you're here to talk about that, especially in finding an effective site and planning a mass vaccination clinic. And specifically, you use something called geographic information systems that you were going to talk about.
That's right. Most of us are familiar with using maps in our work, especially in tracking diseases or in epidemic situations. However, few of us have had experience in planning large-scale mass vaccination campaigns. Many county health departments have access to county-supported GIS programs. So the local health department and GIS can work together to support mass vaccination campaigns. GIS is really a computer-based tool for mapping. When you combine spatial data with non-spatial data and put it through the geocoder, the GIS geocoder, you'll come out with a map that has a specific place on it marker for you, which in this case would be considered a clinic.
And one of the most valuable resources available right now is simply the American Red Cross, who is out there in all the different communities. Here to talk about that is Gregory Smith. And talk to us about the American Red Cross, because many agencies look to you first for setting up emergency crisis situations. What is your secret?
Well, the secret to the Red Cross is our ability to mobilize people and things, and the fact that we are in every community in America and in the United States territories, with volunteers and paid professional staff that are ready to be mobilized, to go from one to either assist in that local community or to go to another community to assist that community. We're also have a lot of experience in standing up and managing service delivery, points of service delivery. Our experience is mostly in that ability to mass mobilize people, the experience that we have in managing large service delivery facilities and service delivery populations.
And part of your ability to do that is also the fact that you have so many collaborating agencies.
The work that we do is almost totally collaborative in that it's not just the American Red Cross that are providing these services. And to ensure that these disaster or other needs are met, it has to be a coordinated effort, a coordinated collaborative effort between agencies and entities that have the ability to provide. That's why pre-disaster conversations, pre-disaster planning, that's so vital.
Christian, you were instrumental in helping develop the state of California's bioterrorism preparedness program. Talk to us about maybe using the Red Cross as an example, and also who is responsible in collecting all this data that you need to create a good plan?
Yeah, that's actually a tricky, the data portion is very tricky and still continues to be tricky. But in developing a plan, Amy and Linda and Greg already alluded to, really it requires just a lot of pre-event planning and really getting the place that you need and really sitting down and realizing that not one size fits all. And that's the first most important thing. And then really coming from there and collecting all that data is really difficult. And really who's responsible for that and where that goes is, I would say, probably still up for debate. And it really depends who runs the clinic. Our plan from California was really more of a guide, probably similar to what the Red Cross's plan is, really to say these are the things you need to consider.
So the collection of data and the management of data is still under debate, but from a state level, in planning the bioterrorism preparedness plan, how do you share information?
Getting the word out is probably the biggest thing. So when we went to a number of different stakeholder agencies. So for example, we go to the local, the Coalition of Local Health Officers and would say, please distribute this plan, have them read it, give it to friends, family, your pets, whoever wants to read this plan, so we can get feedback and make sure everybody knows. And this way, coalesce the information.
And is that your experience, Linda and Amy, in terms of trying to share the data that you've collected?
Yes, I think especially in California there are mutual aid districts, and those different counties talk to each other about their plans and decide on those plans. I think since the viruses have no borders, that we also need to think like that, and that we need to do cross-border planning.
Christian, you had been focused on pre-event planning, and you wrote a response-based model specifically based on mass prophylaxis clinics. How do pre-event and post-event models compare to one another?
In hope they should be identical. And at least in our plan, what we talk about is your goal is, from a pre-event standpoint, to be identical to the response standpoint. And we realize, there's to be circumstances where that doesn't happen, but that's really the reason you prepare and exercise. So when you sit down and read a pre-event plan and you create a pre-event plan and get your GIS information and your staffing populations and all the public and private entities that are going to play a role, and you exercise it and run through it, and you hope that the day comes when you really need to vaccinate people, when it's the real deal, that it runs exactly the same way.
But setting a physical clinic, is it different than setting up a prophylaxis clinic?
Overall, not really, no. I mean, it becomes the subtle differences then where you're dispensing a pill and mass prophylaxis versus giving a vaccination.
One of the biggest tools that we have is trained personnel, and you all alluded to that. And there is the issue of the concept of surge capacity. So you can plan all you want, but when disaster hits, maybe you're not fully prepared for that. So where do you get an army of personnel and staff for these clinics?
There is no challenge in getting individuals to volunteer. Those who have the skill sets and the competencies that you need, and those that do not. But the main issue here is you have to have a plan for dealing with that. There has to be, when you say come on down, you have to be prepared for people to come down and take advantage of this offer.
Maybe give some final thoughts on what you would like for the people who are watching this program to walk away with.
I'd certainly like to, again, stress the notion of the relationships that it takes to produce the type of collaboration that it needs to vaccinate 12 million or 1 million people or 500,000. We can scale this out as far as we want. And the one thing that we didn't touch on was the notion of documenting these relationships. Though it's the piece of paper that you write, a memorandum of understanding, a statement of understanding, or a letter of agreement, though that piece of paper does not the relationship make, it is the foundation for that relationship. And it outlines the parameters, the scope, the intention, and the purpose of whatever the collaboration is. And the more that you can do that and you have that reference of this is what we decided that, very simply, this is what we decided that we were going to do together.
Every single person that worked at our drill had a job action sheet, and it's very specific, you know, learn how to do this, and I think in a real emergency you would actually have to check off the time that you did it. If you wanted to be reimbursed through FEMA or something later on, it becomes an issue, but it's a tool that is a good training tool that can be worked on now. Job action sheets.
Our plan actually has a job action sheet for every position in the clinic, so if you download it from our webpage, we can do that, so it's all on there. And the main thing probably people need to walk away with is really planning is the key. Yes. And starting out, you know, with simulation, and just like Amy said, where you sit down and think about it and how many people will need and what are we going to do and what MOUs do we need to create, all the way to testing it through. Because the idea is hopefully when this happens, you know, just like firemen exercise on a regular basis, as well as, you know, the military personnel with live ammo, you know, going to do your job for real, it shouldn't feel a whole lot different than when you did the exercise.
But as we look at the scale of the work that needs to be done, we need to have a change, a paradigm change, a shift in the way that we use or think about using volunteers in our work. It's not possible really for us to do a large-scale campaign without using many, many thousands of volunteers. So we have to develop partnerships with those in the local community to be able to fulfill these tasks.
And with that, I want to thank you all, Amy Pine, Dr. Linda Quick, Dr. Christian Sandrock, and Gregory Smith, for your time and your invaluable expertise. Thank you very much.
Thank you.
Thank you. All right. And when we come back, our live panel will address your questions. We are now live here in San Diego to answer as many questions as we can during the next few minutes. Contact numbers will appear on screen throughout this segment. With me in studio are Amy Pine, Dr. Howard Backer, Dr. Christian Sandrock, Gregory Smith, and live from CDC via satellite in Atlanta is Dr. Pascal Wertley. Before we begin, a resource for those of you interested in GIS planning resources is this book, GIS for Health Organizations, which is available along with a tutorial disc. It's available online at www.esri.com. We're going to begin now with Amy Pine. Now, you had mentioned moving so many people through per hour. How did San Francisco evaluate its drill?
We evaluated our drill in 4 ways. The most important, first and foremost, was that we did a time motion study, which was really important in the information that we gathered. Through the time motion study, we hired a consulting firm, and they were able to point out to us the bottlenecks in our drill, how well utilized our staff was, how long each station took for every patient, and how long it took to go through the drill overall, how many people could come through an hour. The second tool that we used were patient evaluation forms. Every patient completed a patient evaluation form, and the incentive for completing it was that they entered a raffle, and you could win prizes like gift certificates to a restaurant or a department store. We used staff feedback forms, where we asked the staff questions about the communication infrastructure during the drill, how well they were trained, and if they had the supplies that they needed. And then maybe the most valuable lessons that we learned from the drill came from the fourth thing, which was that at the end of the drill we conducted debriefing sessions in each area and quickly asked the staff who were working there that day what worked well here, what did not work well, and we compiled all of that information and got a lot of valuable inside out of it.
Right, the follow-up is so crucial, and documenting that follow-up as
Right,
well.
right.
Gregory Smith, we're going to talk to you now about dealing with different organizations. With whom do you have to have a standing MOUs, and how often do you have to revise them?
Well, it's important to have standing MOUs with emergency management, with faith-based organizations, with voluntary organizations, to provide that level of assistance for, in the opening, you could see long lines of people, and there was discussion about the various stations within the clinic. And you can have volunteers and others to support those activities and to support that work if you have those standing MOUs that describe how you're actually going to work, and if you include these organizations in your drills. It's important to keep the agreements updated with when there's changes in how you plan to work together, maybe changes in locations, changes in procedures or policies. It's really important to have those updated, and if the MOUs contain contact information, it's extremely important that that contact information is updated.
So usually on a yearly basis?
At least on a yearly basis, and depending upon the level of activity related to planning and preparedness, maybe more, sometimes less, but it's just very important that the document doesn't just sit on a shelf and just collect dust, that you do bring it out and you make sure that all of the information in it is relevant.
Okay, very good advice. And now we're going to speak to Dr. Pascal Wortley. San Diego mentioned using BT funds to purchase vaccines for their drill. Does that mean local health departments can use BT funds for our drills and exercises?
Yes, in fact, BT funds can be used to purchase flu vaccine for exercises. And areas that are interested in doing that should contact their BT coordinator to learn more about the details. CDC does request, however, that such vaccine not be used for groups who have another source of payment, and that would be specifically Medicare beneficiaries.
Okay, thank you, Dr. Wortley. And Dr. Christian Sandrock, how large of a space is really needed to hold a prophylaxis clinic, and what other aspects should we be keeping in mind?
I think, it's kind of a tough question to answer because it really depends on community need. And some communities, they can get away with, for example, a large gymnasium. I've seen some plans set up inside arenas and stadiums, depending on what the need is. For example, I've seen some sketches of New York where they actually use gymnasiums for such a large city, but they're so perfectly placed throughout the city that it functions well. I think the things to consider that are important are really, can you set up your clinic in that area where you're not going to have a lot of bottlenecks, like Amy mentioned they really looked at in San Francisco. And secondly, that you have good access and entry. You don't want to have a single door where everyone comes in and out. You want to have a couple nice double doors where they flow in and flow out of a separate door without a lot of side doors where people can sneak in and out and cut through the line. So it's really getting that plan locally to fit your local needs and really testing it out, so you don't have the bottlenecks in that particular setup. But traditionally, gymnasium, a large gymnasium the size of 3 or 4 basketball courts is where a lot of communities will start.
Okay, some very good points. And Dr. Howard Backer, will one case of smallpox anywhere in the U.S. initiate a mass vaccination?
Well, I think the decision for mass vaccination will be made in collaboration between federal, state, and local health departments. But I think that it's clear that once, in something like smallpox, once the disease is released again, as the evil genie is out of the bottle, that we don't know how far it'll spread, how far the release would be, and there would be no question that we would want to start vaccination. The important thing is to remember that vaccination will be prioritized, and in setting up and in planning mass vaccination, it's incumbent on the local jurisdictions to plan for the priority groups to obtain their vaccination first, which are the same groups that had pre-event vaccination, and they included healthcare professionals, emergency responders, and those who would be doing field work and public health professionals. So once you do the prioritization, your other challenge is to create an orderly and equitable means of vaccination also. You're going to have to think about the groups who won't be the first to line up. There'll be groups that you'll have to do outreach to. There'll be groups that you have to take a little more effort to reach. And then if you open your doors to the public, you can't just let all the public come at once. And we haven't really discussed, and we don't have time to discuss, how will you determine who comes on what day? Will you do it by alphabet, by alphabet of the last name, or by address, or by driver's license? You have to find some means of creating an orderly inflow of patients or of public for vaccination. And we have to remember that it's possible that politics are going to play as much of a role as science in determining our move to mass vaccination and how quickly we have to accomplish that.
And that politics is one thing that a lot of people don't think about in the pre-planning stage, so it's good that you pointed that out. Amy Pine, we did see in some of your drills people wearing colored vests. How much did those vests cost, and where did you get them?
Well, people can purchase vests through any industrial safety supply vendor. But we got our idea actually from Pima County, Arizona, to use pennies, which are typically used in intramural sports and are a much lower cost option than vests. They cost a couple dollars a piece versus over $10 a piece for the vests. And the pennies are available from any sports supply vendor.
And you had different color vests per location?
Well, the area leaders were all in red vests. All of the employees were in blue vests. People involved in the time motion study were in green, and controllers were in white.
Oh, very good. Howard, we're going to talk to you again. We want to plan an orderly process in our clinics, so how do we prioritize the planning? It's a big question.
I know. Well, we mentioned that just a little bit in my previous response, in that we already know, we've already delineated which groups should have first priority, and those are the groups that are most likely to be exposed. Those are your public health and your healthcare professionals. Those are your emergency responders, and then you have to think of your emergency infrastructure personnel that are required to keep things working in your community. And so you have to start with those. And then the challenge is, and we'll definitely need community partners, and this is where your planning comes in, you have to think of some means of outreach to the community. This is where communication comes in. Without excellent communication that reaches all the elements in your community, people aren't going to know where and when to show up for their vaccination. So again, planning, there's no right answer to this, but it's something that planners have to take into consideration when they're working with community groups.
And something also to consider is emergency responders and first responders, because emergency responders are your traditional, your police, your fire, your emergency medical services. But then there are the individuals like from the American Red Cross volunteers that are first responders, that are providing immediate services to those individuals that either have been affected by this or have become a part of the plan to address this planned mass vaccination. So include in that prioritization the notion of first and emergency responders.
Good point. And Dr. Backer, you had mentioned outreach and marketing, which was a cost that San Francisco had planned. Talk to us about how much the San Francisco drill cost and what were the biggest expenses.
Overall, excluding personnel costs, the drill cost $95,000, a little over $95,000. That included, though, $10,000 that was used to it went to a PR firm to help recruit volunteers, $15,000 to the consulting firm for the time motion study, and over $30,000 in laptops and other computer equipment that could be used in future disasters. Excluding all that, it cost a little over $37,000, and we paid for it from our BT grant.
And so at least a third of the cost is an investment in the future regarding the computers.
Yes.
Dr. Backer, our jurisdiction uses an immunization registry in a large-scale emergency response clinic. Would we be expected to use our registry?
There's no question that in any kind of large-scale vaccination or prophylaxis response, you'd be required to keep some records. And it brings up a few issues. One is, how do you maintain the scope and scale of these records? And for at least smallpox, we had experience with that in our pre-event vaccination. The CDC developed a system called PVS, and many other states developed equivalent systems to keep track of smallpox vaccination. These systems are easily modified to do other vaccinations like influenza or chemical prophylaxis like antibiotics. And many of the states have in fact piggybacked onto their electronic immunization registries to do this function. And it's a natural addition to immunization registries and another way to help promote and develop your immunization registry. And many states are using their bioterrorism funds to help develop their registry to handle this capacity of, because you have to know who's received vaccination.
Sure. Okay. We have just a little over a minute. Next question is for Dr. Sandrock. How do you handle HIPAA and consent to prophylax or vaccinate?
Well, it can be tricky in a disaster situation, and like Howard alluded to, when you have the public there and you already have some political pressures and you have a large volume of people you have to vaccinate or prophylax, it gets difficult. But really informed consent is going to be a process regardless of whether you're getting yourself a vaccination, you're getting a number of pills, either single or a month worth, for example, in anthrax in New York. Regardless of that, there's going to be informed consent. And that unfortunately opens a lot of doors of competence and another number of other issues which would have to be tackled. But that's really the direct way around it.
Okay. And Amy, another question for you. When you took information from volunteers to their drill, did you use that data for analysis?
Yes, all of the information that was on the patient evaluation forms, we actually did the data entry on site in a database and analyzed it later, and that's where we learned that the health education materials that we used at the drill really were not at the proper level of literacy. A lot of people did not understand the health education materials that we used. That was our primary point that we got from the drill, and everything else was very positive, and that they understood the layout and thought it was a well-run drill. Okay, and very briefly, Howard, how did you go from setting up one clinic to setting up multiple sites?
Well, how do we go from that? It's this is what I think Christian and Gregory addressed this, that your one site gives you the basics of how you start out, but then you have to, first of all, you identify your other sites, you identify your staffing needs and go out and find those staffing needs, and anything that can be done in advance you do in advance, and that includes the MOUs that Gregory was talking about. That includes the job action sheets that Amy was talking about, and many of the things that were mentioned in this broadcast. Whatever you can set up in advance, you do. I think it's an interesting question. Maybe Gregory could say, do you have a warehouse with all your materials?
Very briefly, because we're almost out of time.
You plan ahead. You plan for the largest event because it's much easier to scale back than it is to scale up. So if you know, if in advance you have identified facilities and have a plan with certain triggers that say when this happens, then we'll go to this plan and we'll move forward very quickly and it'll be much smoother. Plan ahead, that's the main thing.
And with that, we are out of time. We want to thank everybody for joining us, including everyone here on our live panel, along with Dr. Pascal Wertley, who's joining us via satellite, and thank you for watching. And remember that if you have any questions following this broadcast, you can always email us at info@cdlhn.com. I'm Leanne Kim. Have a great day.